So good morning, everyone. I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of March 19th, 2025 to order at 9:02 a.m. Steve, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Robert Judge is excused. Chris Lehman.
Present.
John Murray.
Present.
Dan Kennedy.
Present.
Chair, we have quorum.
Thank you, Steve. I would now like to ask any board members if you have any declarations of potential or actual conflict of interest in meetings with entities or individuals related to board activities. If you provide a testimony related to prescription drugs to the Oregon Legislature, please give the committee name and date. Mr. Murray, I see you have your hand raised. You have the floor.
Thank you, Chair Bailey. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Using the language of the Ethics Commission, because the PDAB is an advisory board that simply provides information to others who have rulemaking authority, guidance from OJEC is that it appears that at most you would have a potential conflict of interest each time the PDAB meets to discuss a specific prescription drug or related matters. I did testify in February, but I did declare that at our February meeting. So thank you.
Okay. Mr. Murray, thank you for that information. Mr. Hartung, you have your hand raised and you have the floor.
I have a potential conflict of interest due to some consulting I do for the National Multiple Sclerosis Society to support some of their advocacy works. And I know they have a comment in the public comment period today. So I just wanted to make that known.
All right, Dr. Hartung, thank you for making us aware. I now would like to ask if anyone has any proposed changes to the draft minutes from our February 19th, 2025 meeting. And if no one has any proposed changes, I would like to ask for a motion to approve the minutes.
This is John.
Oh, this is Board Member Kennedy. I move for approval.
Mr. Kennedy, thank you for the motion. Do we have a second?
Yes, this is John Murray. I'll second.
Mr. Murray, thank you for the second. Steve, if you could please call roll to approve the meetings from minutes from February 19th, 2025.
Will do. We'll start with Dan Hartung.
I'm going to abstain because I missed about an hour of the meeting.
Okay. Lori Hoagland.
I approve.
Okay. Dan Kennedy.
Yes.
Chris Lehman.
Yes.
John Murray.
Yes.
Vice Chair Amy Burns.
Aye.
And Chair Shelley Bailey.
Aye.
We have quorum and the minutes pass. Approved. Thanks.
Thank you. I would now like to call on Executive Director Ralph Magrish to provide us with a program update. Ralph, welcome, and you have the floor.
Thank you, Chair Bailey. Steve, we're good. Thank you so much. All right. Good morning, everyone. Just a few brief updates. Senate Bill 289, which is our PDAB housekeeping bill that was based on board recommendations, has moved out of the Senate Health Committee. A public hearing was held on March 6th, and where Courtney testified on behalf of our work. And there was a work session held on March 13th where that amendment did pass out of committee with a recommendation to the full Senate with bipartisan support. As a reminder, this bill amends statute to the board identifying up to 9 drugs each year that may cause affordability challenges, moving away from a fixed number of 9. It also switches the reporting requirement for the transparency program to annually instead of quarterly to PDAB. And finally, it removes the generic drug report from being a mid-year requirement to having it incorporated in the annual report. As board members now are also sharing and giving information about their speaking engagements as it relates to PDAB since previous meetings, I can share that I spoke by invitation at the Oregon State Pharmacy Association's Lane County Conference on Sunday, March 2nd, and provided an overview of the PDAB and what upper payment limits are. And Chair, looks like Dan Kennedy has raised his hand. Dan, if I can just finish, and I'll acknowledge Dan was at that conference as well. Next, I can share that next month the board will be introducing our comprehensive communications plan around soliciting input from consumers, patients, and caregivers to offer input once drugs are selected for affordability reviews. We are speaking with OSPA about getting signage at pharmacy counters, likely with a QR code or something along those lines, and a similar request to the Primary Care Association for engagement when folks visit safety net clinics. And we will also be reaching out to legislators as well, asking them to help share the awareness about this information request in their constituent news and certainly other avenues, including social media. So with all of that said, we will be really eager to hear from Oregonians as consumers and patients and caregivers and clinicians as safety net providers, and of course from manufacturers and PBMs as well. Finally, I just want to take a moment and acknowledge the hard work our staff has been doing to bring us to this point today where we will be premiering our data dashboard. I can tell you that this has been a vision for several years for staff to be able to present data to you in a format such as this today for these affordability reviews and our future work in drilling down to review the data itself. Specifically, I want to recognize Heather Doyle, our research analyst, for her amazing work in creating this. I want to thank Steve Kuiman for his patience and tenacity in working through the administrative hurdles to secure this platform for us. And finally, of course, to Courtney Whitlock for her leadership and vision on bringing this data visualization process to bear. So, Chair Bailey, that is the end of my report. I do want to recognize that Board Member Kennedy had his hand up. So,
Board
Yeah.
Member Kennedy, you have the floor.
Yes, and I just wanted to make a quick comment about the Lane County midwinter seminar. Ralph did an amazing job, and it was very well received. So thank you, Ralph, for doing that.
thank you kindly, Dan. And Chair Bailey, if I may keep us moving along, I believe Jesse O'Brien is with us. Jesse is the policy manager at the Division of Financial Regulation here at DCBS, ready to provide his legislative update. So thank you, board, and welcome, Jesse.
Yeah, thanks, Ralph. And good morning, everyone, chair and members of the board. I'm Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation. And there is shared in the meeting here, screen shared a document that kind of covers the major pieces of legislation that are probably of most interest to the board that relate to prescription drug pricing, or in a couple cases directly to the activities of the board. And I'm not going to go through these individually, in part because there's really just kind of one big picture update for most of this, which is that there's a work group meeting that has been there's a work group that has been meeting, that is, for the past couple of months to try to work out the possible next steps with PBM regulation and PSAOs and all kinds of related issues there. And the stated intent of that is to combine a bunch of the bills that relate to those topics into a single bill to address all of the issues. Representatives Deal and McIntyre have been very involved with that. My understanding is that there is supposed to be a final meeting of some kind actually today. So there may be a more specific update at the next board meeting about where all of that is going. But as of now, we are still in a little bit of a holding pattern on frankly, the majority of the bills listed here. And then as far as other bills on other topics, Ralph mentioned the most significant one that has seen action, which is Senate Bill 289, which includes a number of kind of technical fixes for aspects of the board's work. And that one is moving forward to a Senate floor vote, although I don't believe it has been scheduled yet. And then the other bill that I might mention is, well, two other bills I would mention. First of all, House Bill 2599, which I think we talked about a little bit at the last board meeting, is a bill that would make some changes to the relationship between the board and the drug price transparency program. And that had been scheduled for a public hearing, but then the hearing was canceled. And since then, it has not been scheduled for any activity. And I at least don't have any particular updates on what is happening with that. So remains to be seen. And then the only other bill that we already are seeing some action on is at the very end of the list, which is Senate Bill 533, which basically would prohibit drug manufacturers from interfering with the acquisition of 340B drugs. And that has a work session scheduled for next Tuesday. And we will see what happens with that. So I think that's everything on my end. I'm happy to answer questions or provide any other information that might be helpful. If not, I'll hand it back. Thank you.
Thank you, Jesse.
Thank you very much for the update. So this portion of our agenda is for public comments submitted or requested in advance. The board received 38 written comments, which are reviewed by the board and posted on the board's website. Those some of the public comment letters that we received are from Daria McGrew at Pharma, Peter Pitts from the Center for Medicine in the Public Interest, Scott Bertrani from Health HIV, Jessica McBride, Oregon Coalition for Affordability Prescription Drugs, Seth Grenier, National Multiple Sclerosis Society, Rainier Simmons, Community Action Network, Harry Giwanter, Let My Doctor Decide Action Network, and Voices of Healthcare Action, 31 comments there. I would now like to mention that the board received 4 requests to speak. I will call on the individuals who signed up to speak and ask them to state their name and organization. They will each have 3 minutes to speak. The board will not deliberate on issues or requests during this time. The first individual who is on my list here is, let's see, Daria McGrew from Pharma. Daria, if you're here, welcome. And you have the floor and you have 3 minutes. Good morning.
Thank you. Good morning, Chair and members of the board. For the record, Daria McGrew on behalf of Pharma. Thank you for the opportunity to comment. As I said last month, I really appreciate the board taking a new approach to stakeholder engagement with these RFIs, and we appreciate the changes from last month to keep personal contact information confidential. We would like the board to build out more information on how they plan to proactively outreach to the various groups to make sure that there is robust engagement from these various stakeholders. Although the personal contact being kept confidential is a positive change, we would like to see more information on how you intend to keep proprietary business information confidential as is required by the statute underpinning this board. We would also like you to build out more information on how the data that you are requesting will be used in performing the affordability reviews. Some of the information is quite broad and may or may not be relevant to the affordability reviews. I don't believe we've seen a new template for the reviews yet, if I'm remembering correctly. So some of the information that you're asking for, we're not sure how it will be used yet. We also have some technical questions that remain, that need to be fleshed out a little bit more in these. For example, number 17 in the manufacturer RFI asks for information on patient assistance programs or And number 20 asks for assistance to consumers. So what is the intended difference there? Please explain that. Similarly, numbers 13 and 14 asks for price concessions to plans separated from price concessions to PBMs. As we've said many times in practice, these aren't separate things. Rebate is paid to a PBM who then passes some of that onto a plan, and the manufacturer doesn't know how much is or is not passed on to the plan. So please explain the intended difference in those two questions in further detail. And finally, I want to comment on the new data dashboard. Thank you for all the work that went into that. Clearly, a lot of work went into that. It'll be helpful for board members and stakeholders to have some of this information represented visually. I'd like to suggest more detail in the data dictionaries on how some of the data was calculated. Just one example is package WAC. Is listed as one number, and you, I think, have rolled drugs up, combining multiple NDCs and package sizes. So it's not clear which package you're talking about or if it's an average. And I know that last year there were some manufacturers that could not figure out where that package WAC number was calculated from. It didn't correlate to any of the numbers that they had. So it would be helpful to have more information in your data dictionary on how that was calculated. Similarly, you're showing a net of rebate.
I do want to mention you used 3 minutes, so thank you for your time and thank you for being here today.
Thanks.
I would like to now call on Ms. Tiffany Westrick Robertson from
Chair Bailey, if I may pause us, and Daria, thank you for your comment. I did see our ASL interpreter had her hand up, and I just want to pause and make sure if there are any issues that we need to remedy with her if there are folks watching today that are using that service.
We're good now. Thank you so much. I just couldn't turn on my video. Thank you. I appreciate it.
Thank you. Tiffany, go ahead. Thank you.
Perfect. Thank you, Ralph. So Tiffany's with AI Arthritis each and the PIC Coalition. Tiffany, welcome, and you have 3 minutes.
Great. Thank you so very much for this opportunity. So yes, AI Arthritis is for International Foundation Autoimmune Autoinflammatory Arthritis. I'm a person living with non-radiographic AXSPA, axial spondyloarthritis, and also the founder of the National Coalition that has a Patient Inclusion Council. And I'm going to talk a little bit today, and thank you for listening to our comments. We submitted our very first Patient Inclusion Council letter to the Oregon PDAB, and the response to our red lines for the patient-facing survey is so much appreciated. I wanted to just mention also that I wanted to take the opportunity as we're going through the drug reviews again today, that there's always this question of affordability for who. And I know with Oregon in particular, there's this multifaceted who it will be affordability for. And we just really want to encourage that the patients and the ones that have potential issues with out-of-pocket costs should always first and foremost be of consideration. So in saying that, I also want to give you kudos for the new drug database board. That must have been a lot of hard work. So kudos on that. We do want to take the opportunity to remind anyone who's viewing it that the drug information that shows list price is not what a patient pays. And I mention that because it has been frustrating to watch other PDABs reference these numbers as actual patient out-of-pocket costs, and in turn rule drugs unaffordable. So we do trust that the Oregon PDAB will acknowledge these numbers for what they are and listen to patients regarding affordability challenges or successes. For example, if we pay $0 for the drug. I just wanted to again give you kudos and thank you so very much for listening to the red lines that the Patient Inclusion Council submitted. I myself have a research background. Many people in the PIC are patient research partners. So this was a very robust analysis we did, and about 80% of what we said was included. So thank you for that. There are still a couple additional that we would like to work with you on. In particular, the question, if on patient assistance program, how much did it cover given estimated dollar amount or percentage? Most patients would not know what a dollar discount would be or a percentage. So just rewording that will give you more robust information. Finally, thank you again for including patient organizations. This has been a struggle for us and other PDABs, and the fact that you are including us in the process is very much appreciated. Finally, I just want to remind you, we are here for you to help you in any way possible to ensure that the patient voice and our real world experiences are captured. So please lean on the Patient Inclusion Council and the EACH Coalition as needed. Thank you.
Thank you very much for being here today. I do want to acknowledge the next individual on our list who signed up to provide oral testimony is Ms. Lauren Sant from Caring Ambassadors Program. She did reach out to let us know that she did have a meeting conflict during this public comment period. I would now like to call on Mr. John Mullen from the Oregon Coalition for Affordable Prescription Drugs. Mr. Mullen, welcome. You have the floor and you have 3 minutes.
Thank you, Madam Chair, members of the board. For the record, John Mullen, Board President of the Oregon Coalition for Affordable Prescriptions. We've testified a few times before you, and just note that lots of the testimony has been from the industry itself and from entities that receive grants from the industry. And I just want to point out that the Oregon Coalition for Affordable Prescriptions do not get any funding from the pharmaceutical industry. And we're interested in greater transparency of the industry and also affordability, both at the purchaser level and the individual level. And I just want to, just as an aside, I want to thank you for the work on the QR code and getting additional input from individuals. It's sometimes very difficult to get individuals to show up for meetings and make comments. So I think that will help give additional grounding to the board. We have all along supported the idea of you moving forward and supporting the work of PDAB from the beginning, when we supported the legislation that created the PDAB to the work up to the present day. We just acknowledge that the work is difficult, but we feel a sense of urgency about the needs of individuals out there that are struggling with their prescription drug costs. I just want to go to the end of our letter, which hopefully you've had a chance to see and read. But our board is made up of advocates, providers, unions, and we have a lot of really good discussion and input about our particular role, which again is about transparency and affordability, ultimately the affordability. Just a personal note about my own signature there, as it were. The word Chandana appears after my name. And I just want to point out that's this is the week of St. Patrick's Day. Chandana is an Irish word which generously means elder, and in a pedestrian way, it just means old man. I've been at this for 50 years, and I just want to say to the board that we've done a lot of difficult things in Oregon that involve a lot of important work. The work that you're doing is difficult, and I commend you for it. And also to just say that Oregon has been a leader and an innovator for all of these decades, and I look forward to you making progress on this important issue. So thank you very much for the opportunity to testify.
Mr. Mullen, thank you. I do also want to mention for the record that Catherine Chandra from Genentech did sign up to provide oral testimony, but was no longer available to testify, as well as did Nathan Salser from who's a consumer. So for the record, I just wanted to make sure to mention that here today. I now would like to move on to a board discussion related to affordability review request for information. Today, the board will continue its review of the request for information forms that will be part of the affordability review process. The forms are designated specifically for the following groups: individuals with scientific or medical training, medical providers, pharmacists, professors, and others in that group of individuals, manufacturers, patients, caregivers, and advocacy groups, pharmacy benefit managers, and safety net providers, also known as 340B qualified covered entities. Once the board has selected a subset of drugs for the affordability review, we will post the forms on the PDAB website and send the links by email. Courtney Whitlock, Senior Policy Analyst, will now lead us through the discussion. Courtney, welcome, and you have the floor.
Great, thank you, Chair Bailey and everyone. This is going to be kind of a quick conversation, this in the sense that we did have some updates to the request form, thanks to all the public comments. We got a really great insight to how to update those to be able to receive meaningful input and information. And happy to still continue to apply updates that will ensure the best response. There are some questions on the forms that are in alignment with our statute, just to see if we can collect some of that information. I do understand that some of it is, you know, considered trade secret or anything like that. It is up to the manufacturer to disclose, or the PBMs to disclose any of that information at their discretion. However, just trying to find the best alignment for what is the requirement, and also the challenges that we have of not being able to review trade secret information in executive session due to possible media being there. So this, we're just trying to work as best as possible to collect the information. We have we're still working on the full analysis of how we're going to incorporate that. Just know that majority of the information that is received will be put into the material packets for each of the drugs. And we will go over kind of the updated material packet over the next couple of months once we have identified the subset list and we know how many drugs we're going to be working with. I did want to take an opportunity just to share what the send out of the surveys will look like electronically. I'm going to be sharing the patient and advocacy group one, but they're all kind of set up as the same dynamic. So again, it's an electronic link with the instructions at the top. Red indicates the requirement of a fill out section. The drugs will automatically be input into a drop-down list for selection through there. And then the rest of it is kind of voluntary information of whatever individual feels most relevant to put into the survey. And then we collect that information, and again, it will be associated closely with the drug under review. Majority of this, such as zip code, age, and all that, is just to help ensure additional analysis, especially around the health and equity component of our statutory requirement. We're hoping that this will provide some sort of insight, especially around the those who are organ residents. We really want to make sure we're capturing as much of that as possible. The caregiver one, patient caregiver one, is the only one that is asking kind of for the age group, the annual income. Again, just for analytic reasons, to ensure that we're capturing as much information as possible to show the inequities component to it. Multiple submissions can be, so if a patient is on multiple drugs or a manufacturer wants to report multiple drugs, once you hit submit, there's a little thank you note, and then under the thank you note is a link that says submit another response. The individual can hit that and it takes them right back to the beginning. They can fill out another drug. So hopefully it's pretty streamlined. And then we have an analysis running in the background for every report that comes in. So it helps us quickly identify what the impact from the drug is. So again, all of them are set up the same way, but I wanted to ask the board if you had any questions. I know I've worked with some of you pretty closely with questions and ensuring that this process is going to be as easy as possible, but I want to give the board opportunity to discuss kind of the setup from staff on this. No feedback or suggestions? All right. Again, the copies of all of the requests for information were printed in the PDF form. So I just wanted to show structurally what the draft would look like. Once the board submits or selects your subset list, staff will work to ensure the names are put into the drop-down list and then also submitted over in the data call. All right, Chair Bailey, if board has no discussion on this. Oh, Dan Kennedy, I see your hand up.
Yes, just a quick question, Courtney. I see that number 1 is a required field. Are there other required fields? Is that number 2 with sort of like a displaced asterisk there, or?
Yeah, that has to do with how the line got cut off. So there's
Okay.
so much I can
So-
do get that to.
Yeah, are those two the only required elements or the
Except for if they're organ residents, again, trying really to ensure that we're capturing as much within organ as possible.
Okay, great. Thank you.
Yes. Any other questions? All right, then, Chair Bailey.
Thank you, Courtney. No, I mean, I do want to make a comment here because you alluded to it earlier. I think for the record, it's important to mention that one of the challenges that we have as a board, that is something I do think we have to together talk about at a later time, is the limitations that we have related to executive sessions and media being present. With media being present, the challenges of getting information, even that we would redact and make, we would redact before we made it public, makes it very difficult for us to get that information. So I'm kind of putting this forward as a plea to my colleagues to think about for a later time. But specifically related to PDAB, we need the flexibility to not have media in sessions where we talk about those things so that we could have meaningful discussion. So that's just something that's been on my mind greatly as I've participated in this board. And it's just something for the record that I want to state. But again, we're moving forward with what we can do right now, but I think it's a very important topic to put forward.
And Chair Bailey, if I can just flag if Member Kennedy still wants to say something or just has his hand up inadvertently still. There we go. Thank you.
Okay, thank you. Sorry, I assumed without asking. So Courtney, thank you. We are now transitioning to the board review of data sets and OAR 925-200-0010 criteria for upcoming affordability reviews. One of the purposes of PDAB is to conduct affordability reviews on prescription drugs and insulin products. Today, the board will review and possibly vote on a subset of prescription drugs and insulin for affordability reviews. The preliminary lists are posted on the PDAB website and links are included in today's agenda materials. I now call on Courtney to lead us through this discussion. Courtney, you have the floor to help us through this discussion.
Yes, thanks, Chair Bailey, but we did skip an agenda item, so we need to backpedal for just a minute, but hopefully the board captured all
Carrier
that
template, would you like to talk about, do we need to talk about that before we proceed? Yes, of course, we would need to do that. So Courtney, thank you. We do need to now speak about the board review of the carrier data call template. In January, the board reviewed the data call template requesting information from insurance companies as part of the board's affordability review process. Today, the board needs to continue its review of the template. So Courtney, if you could please help facilitate leading us through the discussion of the data call template. Courtney, thank you.
Thank you, Chair Bailey. Appreciate that. So I'm actually going to have Heather Doyle step in to provide an oversight of the data template. So the data call template was discussed a couple months ago as an overview. Staff took suggestions based off of public comment and board feedback and provided additional updates to the template before submitting to submitting out to the carriers once the subset is selected. So Heather, I'm going to pass it over to you to share your screen and just provide an overview of the updates that have been applied since the last discussion on this.
Okay. Can everybody see my screen? Okay, thank you, Courtney. So again, to recap, Courtney, what she said is that this has been presented and we did make some changes based on some feedback. So we'll go through that quickly. The first page here is fairly unchanged with the exception of representing the changes throughout the rest of the tab. So we do have all of these sections that can be reviewed for instructions for each of the page that are included in this data call template and links to various parts of those instructions or parts of the workbook itself. We included an NDC information to help with the formatting of the different NDC characters so that we are consistent with our 11 character field. Definitions were updated and alphabetized here as well. Also, facts and questions were also included. We had a few more, and you'll see this yellow one is also for to be determined date. The company information is collecting all of the same information, just reformatted in a different it's vertical rather than horizontal. Data limitations and notes have no change. The claims tabs were changed. It was inclusive of pharmacy and medical on a single tab. They have been separated. So there is now a pharmacy tab and a medical tab, which will help us analytically on the background with all of these claims that are submitted. So the pharmacy and medical are identical with the exception of that distinction. The plan design, we added a couple of fields. Is this large enough for everyone to see, Courtney? Yes, okay. So we've added the columns K and through column O for helping to capture some of the enrollee maximum, minimum, average cost and therapeutic alternatives and the corresponding number of those for a given drug. Please keep in mind that this is fake data that we use for the purposes of setting up the template. It's not representative of any singular NDC drug or therapy class at this time. That'll be populated once the subset list is selected. In the price concessions tab, we have the one change that we made here is formerly we had the manufacturer and PBM price concessions incorporated into two columns and they were together. Those have been separated so that the manufacturers have their own and the PBM also has their own. The plan types reference did not change. And this is here as it is referenced in the plan design in terms of plan types that can be selected for the plan type field. I think that covers all of the review for this particular template, but are there any questions from anyone on the board for any of these changes that you see or other questions for this data call template? John.
Thank you, Heather. I guess I have a question about the data and what is required to be supplied by the carriers. We got a letter that was rather critical of drug affordability boards in general across the United States. And I personally think that this, and especially Oregon's hopefully, can bring transparency to what I consider a quagmire of prescription delivery system. What parts of this form are required information or legally required to be supplied information? I know, the RFIs, that's voluntary, and we appreciate people supplying information, and I understand if they don't want to out of concern for one thing or another, but how much of this form, what are we going to get out of this that can't be denied? I guess is my question. Please.
I'll answer your question from the purposes of the template itself and invite Courtney to add to that as soon as I finish that. But when you look at these fields on the screen, the ones that are highlighted in yellow are indicated to the carriers as required. So once, for example, if something is selected here, it goes away because the yellow indicating that required field. And this happens throughout the template in various fields to indicate to them that. But in terms of other parts of your question, Courtney, is there anything you'd like to add to that?
Yeah, actually, I'm going to hand it over to Ralph since he's probably eager to answer this one.
Thank you, Courtney. Yes, so John, as a practical matter, I'll defer to staff on the specific data points that are statutorily required, but to your specific question about the ability to collect all of this data is actually being collected by DCBS under the authority of our Director's Inquiry Authority that is uniquely granted to our agency and the Insurance Commissioner of the state specifically. Along with that, though, there are some parameters that come with that, specifically the need to aggregate and de-identify the data in a meaningful way that does not distinguish any individual character. Sorry, that was, I said carrier. So to that point, there will still be ample opportunity for meaningful analysis so long as that is de-identified at the carrier level, that I think will still provide very meaningful information and opportunity for data storytelling. So hopefully that answers your question. If not, happy to have you do follow-up and then invite Amy.
All right. No, that answers my question. Thank you, Ralph.
Sure. And then real quick, Amy, Courtney, anything that you wanted to layer on in terms of statutory requirements or anything else?
No, you've captured all of it, that we are under the director inquiry to do such, and everything is within our statutory limits to to collect this information as long as it's aggregated. So
Great. And
Thank
Dr.
you.
Burns.
I just wanted to give Heather just big ups for this. This is great. I think that the work that you're doing is really good. You're getting a lot of really important nuances into this that, you know, as somebody who kind of lives inside of some of this data, like I think this is good. It's hard to marry some of these fruits together. It's apples and oranges. It's not apples and apples. So really good job. Really, really good work, Heather.
Thank you. Thank you very much. And if are there any other questions or comments before I pass it back to Courtney for us to move on? Okay,
right.
back to you then, Courtney.
Thanks. And just, you know, again, Heather has really come in and has revamped this template to really ensure the best collection and analysis of the subset drugs that will be selected in our next process. And, you know, she worked really hard on the dashboard as well. So, you know, a lot of credit goes to Heather and her time and her ambition to really set the board up with meaningful data going forward. So with that, Chair Bailey, I'll hand it back to you to give an introduction to the next section.
Yeah, I mean, the part I skipped over. So we are now moving forward with the board review of data sets in OAR 925-200-010 criteria for upcoming affordability reviews. One of the purposes of PDAB is to conduct affordability reviews on prescription drugs and insulin products. Today, the board will review and possibly vote on a subset of prescription drugs and insulin to be considered for affordability reviews. The preliminary lists are posted on the PDAB website and links are included in today's agenda, in today's meeting materials. So I do now call on Courtney Whitlock, Senior Policy Analysis, to help facilitate guiding us through this discussion. I do also want to mention that we will take a brief 5-minute break at approximately 10:30 a.m. Pacific. Courtney, welcome, and you have the floor.
Thank you, Chair Bailey. All right, so just to follow up and recap from last month, the board had a really great discussion about how to look at some of the approaches for the affordability review. I'm going to share my screen to, thank you. I'm going to share my screen to give a highlight of the discussion from last month. Of what the possible options were, or the approaches to do a drill down list. And again, when in a few moments we'll start kind of running through it, the removal of some of this would be through the dashboard. So again, with the orphan drugs, the statute says designated. We cannot review drugs that are orphan designated. Hopefully in the near future, we can find ways to review drugs that are orphan based that can help create meaningful review. So that was one suggestion, or that's not a suggestion, it's a requirement. Also, another suggestion was to remove the drugs from the IRA CMS list. Understanding that primarily the IRA CMS list impacts the Medicare, but with the implementation of the new pricing starting in 2026, the concept is to hopefully have an overall impact across the system going forward. So, you know, even though we're reviewing drugs from a prior year of what happened within that year of the review, also understanding that over the next couple of years, there will probably be an impact of the cost for those drugs. Another discussion was to remove vaccines. There was quite a bit of discussion in the last review to remove vaccines, ensuring that most of them are due to low patient cost and, you know, associated with public health. Same with HIV medications, where a majority of it is considered low patient cost and is considered a public health medication for those individuals. Therapeutic alternatives, Robert Judge had provided this suggestion to look at drugs that had 3 or more therapeutic alternatives, because the understanding is basically drugs with multiple therapeutic alternatives have possible market impact. So removing drugs that are known to have multiple indications for therapies, but then seeing how those would impact other drugs in that same therapy type. Generic drugs, I did analysis, and there's not very many generic drugs that actually create an impact on cost of the healthcare system. So it'd be up to the board if you wanted to include any generic drugs that you find or remove them off. And then again, focusing kind of on the total spend of the drugs. And the dashboard today should really help with some of the drill downs and decisions of this. So I'm looking forward to the board kind of having meaningful discussion with the help of the visualizations. But before I stop sharing screen, was there anything else? Oh, there was one other thing we had a discussion on, which was removing drugs that were only identified as most prescribed. So again, in the last review process, the board did decide to remove any that were just under the indication of most prescribed, knowing that these are just the high utilized drugs. So with that, I wanted to open up to any of the board members if there's any other suggestions from last month's discussion about the approach, or if we're ready to jump over to the dashboard. Yeah, Dan Hartung, I see you.
I just want to clarify the process and the outcome here. Can you leave your slide up for a sec?
Yeah.
Sorry. So our task here is to select this subset list that are candidates for affordability reviews. We're to get to a subset list of X number of drugs that are sourced from the carrier, these carrier files, which looking at the carrier file, it's like 100. Not this is just the regular one, not the insulin one. There's 159 therapies or drugs there. And we're supposed to get to a list of maybe 20 or so, or 25 or something manageable that can be, that we send the data, or the data comes back from the carriers again to get refreshed essentially. So is that the general process or the goal for this today?
Yeah, so again, I'm just going to share a quick snapshot. So utilizing Rule 10 that was developed to remove drugs that are not in alignment with a possible impact to the healthcare system or patient out-of-pocket costs. And so using the drill down methodology by looking at therapeutic alternatives, the FDA kind of brand and biologic products, any exclusivity periods and those, that helps remove drugs that don't qualify for the review process. And then once the board identifies, a drill down of the drugs, and yes, those drugs are submitted in the data call template and the request for information forms. And then those are sent out to the carriers for the data call and then posted on the website for the request for information. And then once we get that back, we start, the staff will analyze and put the information in the material packets, which are those lengthy reports that we do for every single drug with the clinical write-ups.
Right. And so aside from the orphan drug thing, which we are forbidden from including, so that's like the really only hard criteria, we have flexibility to consider all these Rule 10 criteria, which are basically like there's stuff about WAC, there's stuff about expedited pathways at the FDA, alternative therapies, things like that. We have discretion in how we consider those criteria.
Yes, and how
to come to the subset list. Okay.
Did that?
Yeah, I just wanted to clarify, like, we don't, we have some discretion basically to consider or not consider these other things. So, okay.
Exactly. Yeah. And what I showed you before was just basically the discussion from last time. And it's also kind of similar of what was in alignment for the last review as well. So, but yeah, Chair Bailey, I see your hand up.
Yeah, and Courtney, I do want to thank you for providing those summaries. And if we could go back to the summary that you provided of what had been discussed previously, I do think one thing that would help guide us as we go through these discussions is I think it might be prudent for us to talk right now as a board about what is specifically on this list to make sure that what we discussed is what we would like to use as our filters as we move forward. Because you shared with us what we talked about, but I think it might just, I'd like to just make sure, does this look like what other board members, so obviously the orphan drug, we have a clear answer on that. But on everything else, I just want to level set and make sure, is it the will of the board for all these other bullet items that we have, alluded to or briefly discussed previously, is it, does anyone have anything on here that they disagree with before we proceed? Because I know that kind of sets how we do some things. So Dr. Hartung?
Yeah, and I missed the conversation last month on when you discussed these items. As I look through this carrier list in some of these things like we have net spending net of rebate essentially. And so some of these things, I think they're worthy to consider, but I guess I'm wondering if we're going to go, we're proposing this list to do these larger, more detailed affordability reviews. I feel like these are the items that, we'd want to consider in the full affordability concern. And I have concerns about kind of automatically excluding things just because they hit some of these criteria that we previously discussed, putting the orphan drug thing aside and saying, okay, we just filter out the orphan drugs. I'm fine with that. But these other things, I'm not so certain we just want to automatically give free passes based on kind of these criteria at this stage. Like, I totally am sensitive and sympathetic to this issue about the affordability of HIV drugs and like the out-of-pocket costs that patients face with that. But, looking at some of the carrier data, the net spending on these drugs is still like quite expensive. And if we're charged with assessing affordability for the healthcare system, there seems to be a signal around HIV that we may want to look at. And I'm not saying we want to do anything, but I have concerns about just automatically giving free passes at this stage. So I'll pause there and let other people talk.
Mr. Murray, you have your hand raised.
Yeah, I understand what Professor Hartung is talking about on the medications, HIV medications, and even the protections that 340B might have or need from PCA point of view. Unfortunately for me, to think about the support that they have and maybe the reason to remove them from the list is such a convoluted support system that just relies on, in my opinion, part of the quagmire that exists in our healthcare payment systems. But so I understand that the HIV medications are expensive. They are. I guess I can go either way. Vaccines, I would like removed personally, but IRA CMS list, it does influence the market beyond Medicare Part D. I see that. Therapeutic alternatives, I didn't understand, Courtney, what Mr. Judge was commenting on. It seemed like he was saying something different than this says, or a greater quantity of therapeutic alternatives, and that we should study it if it has them and the price is still high. Is that correct? And then I also agree with removing generic drugs. They tend to be affordable, generally speaking. The last point of total spend, I would need some more discussion on that for my understanding, please.
So I guess I will make a comment related to the HIV medications. Again, keeping in mind we hadn't made any decisions in our previous meeting. We were just speaking about it. I think one of the reasons why it ended up on our list today and why we also had it in the notes was for a few reasons, but primarily due to public health. And I believe that's why other PDABs have also not had HIV medications on their list, was because of the public health, as well as because of public health and the various state AIDS drug assistance programs. In full disclosure, it is on my professional background that's on the PDAB website. I did previously own a pharmacy that focused on HIV and Hep C, just mentioning that for anyone that may not have known. But that business sold in 2018. But just for my colleagues here today, it's my understanding that the public health perspective related to HIV medications was the primary driver of why those medications were removed. The other thing that we may want to think about is, in previous letters, we have received letters that, for example, specifically Biktarvy had orphan designation for certain uses. So I would want to make sure we all knew that. But Ralph, I see that you have your hand raised, so I will stop now.
Yeah, first, thank you all for the rich conversation and discussion. This is great. I will note, just based on the comment specific to HIV meds and comments in alignment with other state PDABs, I will note that those several states that are being referenced are those that are on a runway or path towards upper payment limits. So I want to just call that out loud, because I think that is one of the triggers that maybe had some folks concerned about potential access issues and 340B pricing. Given that is not on the table in Oregon at this time, I will remind the board that this is simply an exercise in identifying 9 drugs that may cause affordability challenges to Oregonians through high out-of-pocket cost or the healthcare system, with no implications or bearing towards upper payment limits or on the financial well-being of 340B covered entities. Thank you, Chair Bailey.
Ralph, thank you for the reminder that the board does not focus on that at this time. So I do think this is an important piece for us, to work through before we move forward. So at least from what I'm hearing, am I hearing that most of the items here that Courtney bulleted for us from previous discussions are, well, I guess perhaps total spend, Mr. Murray referenced he wanted to have further discussion on, but are there board members who feel have any disagreement with any other bullets here? I want to make sure all voices are heard before we dive into the affordability review piece. Dr. Burns, I believe I saw your hand first. You have the floor.
I want to kind of echo what John said about the therapeutic alternatives. That wasn't my understanding of what we were trying to get at either. I kind of understand what the thought is behind that, but I mean, my perspective was, why would we look at something that had a bunch of alternatives already on the market? That's, in theory, now there's an affordable alternative. So this is a little bit different than how I thought we framed the conversation. So I just kind of wanted to echo that.
Mr. Lehman, you had your hand raised. You have the floor.
Yeah, Chair Bailey, I was going to echo the same things that Dr. Burns just said. I had the opposite interpretation of our conversation around therapeutic alternatives. Mr. Judge brought this up, and I think we asked questions like, why would we look at something that has 12 or 13 therapeutic alternatives when we have many things that have no therapeutic alternatives? So I am with Dr. Burns on that. I think I do agree with the obviously we're taking out the orphan drugs, but removing the price controlled Medicare drugs for not only this year, but the ones that are scheduled for next year. Agree with removing vaccines and HIV medications and also generic drugs. And I don't know, I'm not an expert with Excel, but when I just do those things, it gets down to about 33 medications, Chair Bailey. So I think we're pretty close with just those 4 or 5 filters. And then to the previous question about total spend, I'm not sure I totally understand that either. So if we're going to keep that in there, I'd like to have further discussion just to make sure we're all on the same page and understand what that is.
So, Lehman, thank you. Ms. Hoagland, I see that you have your hand raised. You have the floor.
So, like my fellow board members, I too would like to understand total spend category better, and also the therapeutic alternative that doesn't makes sense to me from our earlier discussion. And then I guess for the generic drugs, and we would be changing this to remove generic drugs and not just specifically those with multiple therapeutic equivalents.
Thank you, Ms. Hoagland. I mean, I will say my personal thoughts is I was in alignment with where I believe, I don't want to speak for him, but where I believe Mr. Judge was going. Again, not speaking for his perspective related to it, but my perspective after he mentioned it was that if there is a drug on the market that has alternatives that is still expensive, that's a flag to say, hey, you might want to look into this more. You may want to look into why is this drug still driving high expense when there are others in the market. You know, I personally believe that likely could be a plan design issue, right? But I think that at least was the lens from which I thought he was headed related to that. Related to total spend, at least my own thoughts on that would be, because we kind of have to look at the cost of a medication throughout the year and not on a one-time, adjudicated transaction, that focusing on something with the highest spend net of rebate, as long as we had a statistically significant number of patients, would be a way to look at it. But Dr. Hartung, you have your hand raised. You have the floor.
The therapeutic alternatives thing, I think is that's a big category of potential within for each disease. You can have, Me Too type drugs that are literally 10 different beta blockers or whatever, like very similar. A lot of people just say interchangeable. Running the gamut to things like the oral anticoagulants, where we have, warfarin and then the direct acting oral anticoagulants, and people would argue if they're truly alternatives. And then you have things, and I know drugs for multiple sclerosis fairly well, and there's 20 or so different drugs there, and they're alternatives, but they're not substitutable. They're not, people would argue if they're really therapeutic alternatives, because it's just needs to be driven by what patient preferences are and things like that. So, I have difficulty at this stage considering therapeutic alternatives in kind of the decision-making process, because I think, we're setting up this candidate list for the affordability concern reviews. And I think at that point, in those deeper conversations where we have this more detailed information, I think that's worthwhile. And thinking about, for a specific drug, what are the alternatives, and are they truly alternatives? And then we'll have information from stakeholders and caregivers and clinicians to inform our deliberations around that. So I'm kind of, at this stage, don't think it's worth considering. In terms of total spend, as I understand it in these carrier spreadsheets, total net spend is a function of both the price of the drug as well as its use, how many people are using it. So I think it's worthwhile. And it functions in terms of is this costing the healthcare system a lot of money? So I think it does a bunch of different things. It captures the overall use in the population as well as the cost of the drug. So I think it's really useful, and I think it should be one of that, in addition to cost per enrollee, should be one of our kind of guiding metrics in how we shake out this candidate list.
Thank you, Dr. Hartung. Vice Chair Dr. Burns, you have the floor.
Yeah, to talk to Dan for a second, I think this is imprecise language, right? I agree with what you're saying. And the way the conversation worked the last time we met was looking more at therapeutic equivalence, right? But in the biosimilar market, they might not be AB rated, so you can't just swap them out. So talking about like, let's say Lantus, for example, not to pick on Lantus, but there's literally like 10 different glargines on the market now. So why would we look at Lantus? So I'm not trying to get at the Me Too's here in this like that, because I talked about this last time. I'm not trying to get at the Me Too's or like, well, we can switch out your Eliquis for, you know, another medication. Like we're talking about things that are a specific biosimilar or generic on the market.
Okay, I'm just using the language that's in the spreadsheet, and there's
Yeah,
a
I
filter
agree.
for therapeutic alternatives that's based on like a drug product that contains a different therapeutic agent than the drug in question, but is FDA approved, compendia recognized as off-label use for the same indication or as and then there's therapeutic equivalent, which is a more, you know, which I believe is kind of so, you know, when I'm just thinking in terms of these filters that are in the actual spreadsheet and how we apply them and saying, well, maybe they don't actually capture what we think that they're capturing.
Yeah, that's fair. I agree with you. I don't think that that's a way that we should go about this as therapeutic alternative, but we really should be, and this is where the conversation went last month, I think, looking at removing things that have a bunch of biosimilars, essentially, not therapeutic alternatives per se. So, you know, the language maybe isn't exactly precise, and it sounds like we all agree that there's a difference even in that with what's being written here, because this becomes like a market competition thing that we have here, which is not exactly where I think a lot of us thought the conversation went last time.
Would it be helpful to kind of go over to the dashboard and kind of, you know, just start drilling down and looking at certain things, and maybe that will help facilitate?
That'll help, Courtney. Sorry, I was trying to get us to make sure we all really looked at this, but I think you're right. We start getting into the dashboard and that will be very helpful.
Yeah, I'm gonna have Heather jump on and share her screen for the dashboard stuff.
Okay, can everyone see my screen?
Yes, I do want to acknowledge, though, that Dr. Lehman has his hand raised. So
Were we going to take a break, Chair Bailey? I don't know if it was 10:05. I can't remember when you said that we were going to take the break.
I think the agenda states 10:30. So if
Oh, okay, perfect. Perfect.
Thank you.
Any other questions before I start?
Actually, Heather, I'm gonna just jump in real quick. Since there are some updates to the dashboard that needed to be done late yesterday, I'm gonna have Heather walk through kind of how the dashboard was set up and with the intention of how to utilize the dashboard. I think just for everybody's knowledge on the call. And then once she does kind of the overview of the function of the dashboard, we'll start drilling into more of the drill down of the drugs. There's a little bit more going on with the insulin drugs, and hopefully we'll be able to capture some of that conversation today with the insulin. If by chance the board prefers to focus on just the carrier data and the drill down, to see if we can get to, you know, any sort of a list or a decision, that would be helpful. We can always come back and talk about the insulin in the next month and then send out a data call if need be. But Chair Bailey, I see your hand up for that. Oh, and you're on mute.
Thank you. One thing I wanted to ask as we start listening to how this was built and proceeding is there any guidance from staff on volume of this first list that is manageable based on staff resources? You know, I recall last year one challenge we had was our initial list ended up maybe in hindsight a bit too small because then we had less flexibility as we were starting those reviews. So do you have any guidance for us as a board on maybe a list that shouldn't exceed a certain number? Or I just want to make sure we're mindful of staff resources and what is actually achievable in the time frame that we have.
I'm kind of hesitant to put a direct number on it. But as you say, with only a few people putting together a packet of 60 some plus pages.
This year we have RFIs and we have meaningful information that will be coming from those.
Yeah, and again, there's a lot of data that will need to be analyzed in a small amount of time. So just I think realistically, no more than probably 30 or so drugs. So you can have meaningful packets and materials. And again, from that subset list, the board will be able to identify what ones will not absolutely be included and what ones can be drilled down even further.
Thank you. That just helps us as we go through this. So I appreciate it. Thank you.
All right, Heather.
Okay. I'll go through, like Courtney indicated, a brief overview for the board. If you have any questions, please stop me. I'm looking up at another screen, so I may not be looking directly at the chat. So please let me know if you have any questions as I go through. So basically, this first page, which is where you land when you go to this link, basically has buttons for every sheet that exists here. At any time, you can go to the logo at the top and it will take you back to the PDAB website. These top 3 buttons are here because they apply to all data sets contained within the dashboard, which is why they're above. And you can click on any of those to navigate to those as you work through this dashboard. In the blue over here and the 3 buttons below are pertaining to all the carrier data. And all of those in green are pertaining to the insulin data. The first page of each data set is a lot like the spreadsheet that you have already seen, just in the format of the dashboard. And we'll go to the carrier data one here. So these should look relatively familiar based on those spreadsheets. There's a scroll bar at the bottom, and you can go across to any of these fields that are captured here. As you do your filtering on the dashboard, you'll see that there's a number counter up here indicating how many drugs are remaining after your filters are applied. These are the filters available to you over on this side. You can select, it's a little bit different if you're using a PC versus a mobile, like an iPad or some type of tablet. So for a PC, when you want to select multiple things, for example, if you want to select more of several of these, you can select all, or you can click Control to select multiple. If you're on an iPad or a mobile device, you can select all and then tap to deselect those you would like to filter out. For clearing all of the filters on a PC, you're just going to tap the button to clear the filters. For an iPad or tablet, you would want to press and hold the clear all filters for that to clear out for you. The carrier pages, as well as the insulin pages in their separate sections, are linked on their filters. So when you take, and let's say that we filter out, for example, brand only on this spreadsheet page, you'll see the number will drop to 113. That's how many are on this list that are brand. And then if you are to go to the subsequent page, you'll see, again, that's reflected here and as well on the following carrier page. So they're all linked so that when you filter on one, you're filtering all 3 pages by the same parameters. And again, you can clear all those out and start over if you would like. From each of these pages, there is a button at the top that will take you back to the main navigation screen if that's where you'd like to go, or to the terms and metrics if you want to look up one of the definitions that's included in the dashboard. When you go to any particular visual, for example, we'll go back to the data table. You can also notice that I'm navigating backwards and forwards using the buttons at the bottom, which you can do as well as going back to navigation and selecting another button for a page that you would like to see. On the spreadsheet type of demonstration here, you'll see little carrots here. If you tap on this, it will reorder by sorting them alphabetically, and you can tap on it again, do it in the other direction. For things that have numeric values, you can do the same thing, and it will order them either ascending or descending. You just would click it over again to make it do the opposite direction. You can select a single drug by single proprietary name. All of these are possible from either a PC or from a tablet. Any questions so far before I continue? Okay, the visuals themselves are interactive in its way. Oh, sorry, Dan?
Is there a way to, or can it be in the, can you add a feature where you can actually like limit by numeric, because you have like, some of these like therapeutic alternatives, and it actually lists in all the different integers of numbers that you can select. And same thing, I don't know if you have one for cost, but like in an Excel spreadsheet, you can filter by, greater than X dollar amount or whatever. And so I don't know if that's like can be added to this thing, to this this platform.
You can. There are a couple of different ways to do that. One is just having the raw numbers that you can select, which probably isn't the most straightforward way. There's also a way of doing something called binning, or creating categories that you can select from that would filter out those numeric values. So short answer is yes.
Okay. It might be help. So I just went back to using Excel because I wanted to like look at different quartiles of spending and things like that. And I wasn't able to do that on this dashboard.
Yeah, the filter, that's correct. The filters aren't set up quite that way, but it is something that could be added. Are there any other questions before I continue? Okay, so moving on from the table, if we look at some of the visuals, again, calling out the filters that are on the left, carry through on all of these carrier visuals and pages. The individual visuals here are also interactive. For example, if you hover or on a tablet you tap on this, you will see metrics that have been included for the specific drug that you're hovering over. These are, we call this a tooltip. So the tooltip will show you all of these different metrics. If you want to see up here, these bubbles do the same thing. So one thing that's different from the top and the bottom, aside from the shape of the parameters that you're looking at, is the one on the top incorporates 3 different variables: the proprietary name, the total annual net of rebate spend, and then the size of the bubble in this instance is referring to the WAC. And so the size of the bubble will vary across the visuals depending on what that third metric is. So in this case, the larger the WAC price, the bigger the bubble. So if you wanted to click on a bubble and you say, oh, well, these are alphabetical, where does this fall on the bar chart below? You can click on that single bubble and it will highlight it on the chart below, and it will show you where that stands out. There are scroll bars on each, because when you have a very large list of drugs, it's very impractical to get them all squashed into a single chart. So you may want to scroll left and right to get an overall view of all of where they fall. To undo this filter that you're looking at here, you can just select again, and like vice versa, you can do the same thing with this bar chart. It shows up a little differently on the bubble. So when you click on this, it will put the bubble at where it lands in according to the net of rebate spend up this high, and then it has this size WAC, so you can look at that. You can also deselect and then include all of them. The pages have all been set up in the same way across both data sets, so that there's you don't have to try to figure out how to navigate each one, but paying attention to the titles of the visuals and hovering will help you pick up more information as you go through this. So there are these 3 are the main, so the table and these 2 sets of visuals are for the carrier drugs. For the insulin drugs, again, there's a data sheet, very much like the other one. You'll see the number count is different. It's a different data set. And you'll see some of these look the same: proprietary name, non-proprietary name. However, they're linked to the insulin data, not the carrier data. So if you select something here, it's not going to filter the carrier data. It will only filter insulin data. And the visuals interact the same way. Whatever you filter on this page will carry through to these other visuals. And these work exactly the same way. And in this instance, the bubble size that you see is representative of the number of total prescriptions filled. So with that, that pretty much concludes the wrap up of what the dashboard does. But if there's something that you would like me to navigate to specifically, or you have a question, please do so. Ready for that. Yes, Chair Bailey.
Heather, thank you for walking us through all of this. Because Dr. Hartung, I know, sounds like he exported some things in Excel and did some dollar thresholds. Because we have you here right now, are any of the things that he might have been doing on his own in Excel, if he gave that criteria to you right now, is that something you're able to edit in real time or not? If he wanted to see anything he might be presenting or wanting to bring forward today, or would that be something we would really need to jump into Excel on during the discussion?
It would be difficult to get it published back so that everyone could see it in this way during this particular meeting. But if there's any other direction that Ralph or Courtney would like to add to that, please go ahead.
I was just asking, obviously he'll have the results of what he was looking at in Excel that he could share for his colleagues here, but I just wanted to ask. So thank you for clarifying.
Okay, thank you. And we go back to the navigation menu, and I will come up to one thing that you can do is if you have filtered and you have a list of 30 or so, and I still have this one filter on here, we can go over to the spending and sort by largest to smallest so that you can see them from that perspective as well. I'll go ahead and clear this filter. And that then would lead us back to here, and then I will ask the board where they would like to review, filter, and how you would like to proceed.
Chair Bailey, before we jump into kind of maybe a drill down discussion, do you want to take this opportunity, maybe take a few-minute break?
You were reading my mind. I think although we're early, it makes the best sense before we jump in. So I guess I'd like to announce that the meeting will temporarily adjourn for 5 minutes and we will return at 10:28 a.m. Pacific. Good morning and welcome back. Steve, if you can help support us by helping us do a quick roll call just to confirm that we have everyone here before we proceed.
Will do. We'll start at the top. Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Here.
Dan Hartung.
Here.
Lori Hoagland.
Here.
Hit the mute. Robert Judge is excused. Chris Lehman.
Here.
John Murray.
Here.
Dan Kennedy.
Here.
Have quorum.
Thank you, Steve. And Courtney, I believe you had the floor and were helping us begin this conversation. So Courtney, you have the floor.
Yes, thank you, Chair Bailey. Hoping there's Heather. All right, Heather, if you can please share your screen. Thank you, Heather, for providing an oversight of kind of how the dashboard functions. We're gonna first, does the board want to look at carrier data first or insulin data first? Yeah, Chair Bailey, I see your hand up.
I think it makes the most sense for us to start with the carrier data.
Just ensuring that's the board's preference. So,
Agreed.
yeah, Heather, if you can, thank you. Share that. I guess is starting off with the first drill down component, which would just be to remove orphans. And then the board can continue its discussion on additional options. And then Heather, if you can categorize it by cost from highest to lowest.
And Courtney, I just did want to mention that we're removing orphan because of our statute. I also want to just make sure that we mention here that sometimes we do learn from those in our ecosystem related to orphan. That's been a discussion over the last year. So we do the best we can, and we continue to make progress related to any feedback we receive on orphan.
Thanks, Chair Bailey. All right. So, Heather, it may be easier to start off with the visual. If you want to jump over, yeah, to the next one. There you go. So I'd like to open it up for board. Dr. Hartung, I know that you've done some drill down and have some options about how to look at this. And again, board, if you wanted to look at anything just regarding generic drugs or just brand drugs before making a decision, if you want to stick with brand drugs, we can start kind of with that. And Chair Bailey.
Oh, Dr. Burns had her hand raised first.
Yeah, I would suggest, I mean, there were some things that I think everybody agreed on, which was removing generics and removing vaccines. Like maybe we could start there after the orphans.
Dr. Burns, that was my initial reason for having my hand raised too. I was going to suggest, I guess, after that, since we did want to talk about, or we had board members who wanted to dive deeper in, maybe we did use the next filter as the total annual cost net of rebate. But Mr. Lehman, I see that you have your hand raised, so you have the floor.
Yeah, Chair Bailey, I think the only thing I was going to call out is when I was messing with the spreadsheet earlier, I think you have to take vaccines out and maybe toxoids, because I think there's a couple of vaccines in there that are classified as toxoids, not vaccines. You might want to just pull those up specifically so the group can see what I'm talking about, but I think there's 2 in there that are vaccines. Yeah, that's great. So I would take those 2 out, Chair Bailey, as well, if that's okay.
Rely on the clinicians on the board for that. So that, thank you for catching that and helping support us related to that.
Okay, so removed vaccines and toxoids.
For the list type, did the board want to remove those that are just identified as most prescribed? Or do you want to take a look at what the drugs those are? Yeah, Chair Bailey.
From my perspective, I would remove most prescribed and focus on total annual cost per year, but that's just my opinion.
Any other discussion from the board members on removing most prescribed?
Sorry.
No, that's okay. I was gonna, I mean, we could look and see. I would think that would probably capture a lot of generics that's how I recall that it looked before, but.
Yeah, a lot of, so we've already drilled down to brand name, but Heather, will you pull just most prescribed real quick to see what those were for the brand names? For the board to see what ones they are.
And Heather, while you're doing that, Dr. Hartung, did you have something you were thinking?
Oh, yeah, so I'm going back to like what these definitions are. So basically they're just carriers had just had to submit the 25 most prescribed. Okay, so they submitted multiple lists. So most expensive, most prescribed. Okay. Yeah, I could go along with that. I think. I mean, it could be also one of their more prescribed drugs could be expensive too. So
They're showing on screen right now, Dr. Hartung.
oh, sorry.
So I wasn't sure if that would make a difference in your decision.
Xolair is one of the most. These don't. Is this right?
Again, this is the most prescribed, over 11 carriers reporting it. And then
Also, if you look at
this can't be right.
The list types, the one that's most prescribed it was only on the most prescribed. That's the only one that it was existing on.
Heather, to Dr. Hartung's question, I mean, I think you would need to release all the filters that to the board. The most commonly prescribed are the lisinoprils and the Levox, the generic synthroids of the world that we see most commonly. So I do think there could be a filter problem here if we want to reset that for a sec.
Oh, for the generic, to include generics?
Well, if just to give Dr. Hartung the full context of what that top 25 most prescribed list is, and then if he and maybe if Dr. Burns wants to offer a lens on there too, that if there is anything that is a bolus or an anomaly on that list that should carry forward, we certainly can have that conversation.
Yeah, so again, lots of generics, and there's only 5 brands that were considered most prescribed. The rest of these are generics. Since we just included brands and generics in this filter.
But it's coming through the hierarchy of a number of factors, right? So it's not just that it's the most prescribed, but it's the most prescribed that's hitting a dollar amount amongst the most carriers. So that's why we're seeing some of these things that look odd to us, like Xolair.
Yeah, so
Is that
again,
correct?
the reporting requirement to the drug price transparency program is carriers are
Yeah.
to report their top 25 most costly, most expensive, and most prescribed drugs. So, and then if a drug comes across multiple reporting on those lists, Heather, can you find one that has like most costly, most prescribed? And then if they came across multiple lists, then they were identified. And again, this is across 11 carriers reporting it. So can you find a bubble that maybe has like most prescribed or like the number of carriers on it?
Oh, how
one.
many? Can you restate your question, Courtney?
Yeah, so like right there at the bottom, it says 2023. So this drug came on as the most costly and most prescribed. So that's why it's going to be reviewed under most costly as well. But some drugs just came in and identified only as being most prescribed, which is often the generic drugs, right? Some brand name drugs, the 5 that Heather had shown, were just identified. Can you drill down to the most for just brand name, please, Heather? Thank you. For most, oh, I thought that there was less than, okay, so there's 12 brands.
Well, it's a lot of vaccines. That's why, because we took the
Okay,
vaccines.
yeah, if you can remove the vaccines, and because remember, we're removing vaccines, toxins. So doing the clear all will reset that.
So this has currently filtered as brand. It's showing show on the most prescribed only list and therapy classes of vaccines and toxoids removed.
Okay. Are the orphans removed?
We cleared that, so let's do that.
Thank you. So again, here's the 5 drugs. And so, yeah, Xolair is this identified. How many carriers reported like Xolair as most prescribed?
Oh, let's see here.
I
You
have
said Xolair. Xolair, is that what you said?
Yeah.
5.
5, yeah.
So again, 5 carriers reported that it's just the most prescribed drug for their plan, kind of thing. So that's how that runs. So again, coming back to the question, is it in the board's intention to remove drugs, including the brand ones that are most prescribed? It's only identified as most prescribed.
Chair Bailey.
Oh, thanks. I mean, from my perspective, yes, I think we should be looking at most costly, and then from there, looking at the number of prescriptions. But that's my perspective.
Xolair cost, the annual spend per enrollee net is $21,000, according to the sheet that I'm looking at. So
Yes, you can see. Oh, sorry.
oh,
In the tooltip, it's like the 6th part down, 21,593.21.
261 enrollees. Aggregated down. And I see Dan Kennedy's hand up. Or not.
Mr. Kennedy?
Yes. Okay, I'm unmuted. I just wanted to point out that Omnipaque is a contrast media, and so I'm not sure we should be looking at contrast media typically used in CT scans or that sort of thing.
I mean, it's up to the board, but again, this is just what was reported to us that follows under the reporting requirements that go into the drug price transparency program.
And I guess, Courtney, I wanted to clarify that when I said, when I was referencing remove, I didn't mean something like Zolar will also show up on, if we were filtering by annual cost, I'm assuming that'll also come up on our drill down from that perspective, right? We're just looking at total prescribed volume right now.
Yeah, but if you remove the filter for most prescribed, then it will fall off the list for
It'll fall off the list even if we're using the filter by annual spend.
Yes.
I see. Dr. Hartung.
Yeah, so I was having these issues, when I was exploring this with the kind of the tentative list that was on the PowerPoint slide that summarized last month's discussion. And I'm kind of wondering if maybe a more deliberative process would be, somehow applying a minimum number of filters, obviously orphan, and maybe, I don't know if there's other ones that make sense, and then just like sequencing them in some order, and then just like walking down the line and like looking at each drug and considering these things like the volume of number of enrollees, the IRA list, the therapeutic, just so we don't run into these issues where we're kind of just inadvertently, just because maybe the filter, it's not capturing, Xolair is the most prescribed, but it also seems to be pretty expensive and has a high net spend too, or in total net spend, $5.6 million. I guess that's not, in the grand scheme of things, not huge, but per enrollee seems pretty sizable. So I guess that's kind of what I'm kind of tending to lean towards, more kind of just a considered approach of each drug, and then kind of add it to this tentative list. I know it's not systematic, but I feel like some of these flags we may lose some things that we are interested in knowing about.
Mr. Lehman, you have the floor.
Yeah, I agree with Dr. Hartung on that. I think if we go back out of here and go back to that original list that we had, and is it down to about 50, Courtney, when we filter out the orphan drugs and the generics and I think the vaccines and toxoids?
Yeah, let me pull a spreadsheet up real quick and do.
And the only other thing I was going to say before I'm done is I agree with Dan Kennedy. I think diagnostic products, I didn't catch that earlier, but the therapy class diagnostic products for those contrast agents should come out too.
Sorry, go ahead.
Oh, no, please, complete your thought there, Heather.
Oh, I was just saying I can clear these filters and we can start fresh if that's what we'd like to do. And I know, Amy, you have your hand up as well.
Yeah, I was just going to say I was going to piggyback with what Chris said, really. It's just want to make sure that, Dan, your intention is not to go all the way back to everything with like generics. Like we can at least start with a baseline of getting rid of like those 3 things plus diagnostics, because I agree with that as well. So.
Yeah, like a minimum number of filters, and then just like ranking them by some. I mean, it's not what I was doing yesterday at home was just basically looking at overall net spend and then taking a subset of, like, I looked at the top quartile of net spend per enrollee, figuring, you know, looking at a kind of a hybrid of both total healthcare spend and as well as spend per enrollee, to try to triangulate, you know, what could be the, you know, drugs that have the issues with affordability. Because again, we're creating this potential list.
Mr. Lehman?
Yeah, team, I was just wondering, so with the only other filter that I would think about adding here or be open to discussing would be the Medicare price control list. I mean, do we want, because Medicare is doing that, do we want to filter those ones out before we start, or should that be part of the conversation here? I'm curious to hear what the group thinks.
I mean, Dr. Hartung, your hand is raised.
Oh, part of me doesn't want to automatically exclude them if they're being considered, just because of the, you know, uncertainty about, there's a delay in the implementation of the negotiations. It just hasn't even started yet, even for the first round. And then it's not clear if there's going to be, you know, if there's going to be impact across all sectors of payer groups. So it kind of falls into one of those areas where I just don't automatically, and there's going to be increasingly numbers of drugs added, like 15 Part D, 15 Part B every year. So it's just going to continue to add. So we're kind of paint ourselves out of, you know, potential things to look at, you know. So I think it's something to be considered in the affordability reviews, but at this stage, I don't like the idea of excluding it just based on if Medicare has identified it as also as a high cost drug.
I think Dr. Burns, your hand was raised next.
Yeah, I would agree with Dan. And you know, if we have an idea that they are included, that's great, but I think we should still look at them. Maybe if the list is unwieldy, we can use that as a factor, but I think we should still keep them in.
Mr. Kennedy?
Yes, I would just agree with the previous two speakers. I think with all of the uncertainty currently in Washington, D.C., and I think it would be wise to include those and deal with them later if need be.
Okay, so from what I'm hearing from everyone is that we would like to continue to look at them at this time, but as we further refine our list to the subset, which ideally is at the end of this meeting today, it's a factor that we may reconsider as we have our list. That seems to be the will of the board. Is that accurate?
And just real quick, Heather, can you please go back down to initial drill downs, which is to remove the orphan drugs and to remove the 3 suggested, okay, you get the therapeutic classes, and then just put everything back to brand, just to give the board a better perspective from that view on the dashboard of what they're kind of working with.
And as we narrow the list, I do want to lean into something Ralph referenced earlier as a response to my comment related to HIV medications. You know, as we talk about access or some of the things my colleagues have mentioned related to IRA, make sure, I just want to remind everyone that at this time, we don't have like upper payment limit authority. So just because we're looking at drugs, we're shining light on factors that may or may not lead to affordability challenges. But I just thought that I would remind all of us of that as we kind of alluded to things related to IRA. But Ralph, your hand is raised, so you have the floor.
Thank you, Chair Bailey, and then I'll go to Dan Kennedy. Just a broad comment, using a baseball metaphor, given opening day was just this past couple days in Japan. As the board looks to identify 9 drugs that may cause affordability challenges, I will note in this baseball analogy, this is not spring training. These are not drugs that are trying out for a position on a starting roster of 9 drugs. That is a way of saying that each of these drugs should be looked at individually, not in competition with one another for selection. So to that point, if the board wants to opine or discuss the merits of 1 or 2 drugs off of the most prescribed list, certainly within the appropriate rubric and context to do. If the board wants to look at a handful of drugs from those that were most expensive, regardless of therapeutic category, that is appropriate too. So I just want to say that out loud, that again, the board should not be looking at this in terms of comparator or competition from one drug against another. These drugs should be looked at individuality on their own merits and data points. Thank you. And Dan Kennedy.
Oh, I'm sorry. I'm remiss at lowering my hand. I have no question. Thank you.
So we're kind of with what Ralph just mentioned, just for conversation. Are there drugs that kind of jump out the board that makes the most sense to kind of start to consider for the subset list? Like here we do have, you know, if you're looking at the total annual net of overall spend, you got Humira and the Biktarvy, you know, showing quite a bit of spend compared to number of enrollees and the amount per prescription. Or is it more, would it be more meaningful to go over to the spreadsheet and look at the spreadsheet and see what it looks like from that perspective? Couple options to look at how you want to drill down the.
I appreciate your willingness to mention the spreadsheet, because I do think maybe that's a tool that some board members have leaned into more, including myself. So maybe we could work on the spreadsheet and use the dashboard visual to help us too, but maybe that would get us in an ecosystem that everyone's maybe a little more comfortable with filtering in, to make sure we don't miss something that we might otherwise want on the list.
Okay. Heather, are you comfortable? Do you have the spreadsheet up and can apply those filters? Otherwise, I have it up and I can still screen, and we can just kind of share screen back and forth as need be. Oh, and you're on mute.
It may be easier to go back and forth based on the functionality of the dashboard itself.
Okay,
That's
I'm gonna still screen them for just a second. All right, and board, I already drilled down, utilizing the removal of the 3 therapeutic classes, removal of the orphan drugs, and everything's filtered by brand. So, and I have it filtered from most costly to least by the total annual net of rebate spend. So showing that, again, we have Humira, Biktarvy, Cosentrix, also looking at the number of prescriptions filled, which the average cost with net rebate for prescription was $4,971. And then this also had a WAC increase in 2023. So yeah, Chair Bailey, I'm sorry, I didn't see your hand up.
Oh, thanks. I did want to ask my colleagues, I know we are looking at 2023 data. I did want to ask if it matters to my colleagues. For example, Vyvanse does have a generic on the market. Now, again, it is still in 2023 leading to expenses, so we may want to look into that for plan design, but does the board want to include medications that currently have a generic on the market on our list of potential drugs? Dr. Burns?
Yeah, I mean, I've argued this for the last 18 months to not do that, just because the longer, and you guys know this, the longer something, the patent is off and it becomes generic or biosimilars are able to be made, then in theory, the cost should come down. Now it might not for the proprietary, originator medication, but there is lisdexamfetamine on the market from multiple manufacturers, and we are looking in the rear view mirror. So if we have 9 spots, to me, it doesn't make sense to have Vyvanse take up one of those spots.
I guess I would, Dr. Hartung, you have your hand raised.
Yeah, I mean, I generally agree with that comment. But I also wonder how many spots, just coming back to this, what is our candidate list number? Is it 20?
I think we heard from Courtney that we may be able to go up to
30?
30.
Yeah.
But that would also be including insulin products too.
Oh, thank you for the clarification. I didn't hear it that way.
I just thought about
Thank you for the clarification.
Yeah. Otherwise, it might be,
But the insulin list is only going to be maybe 3 to 5 probably, because we only have 1 insulin we want to add to the list, or at a minimum.
So I was going to propose, Ralph.
Oh, Corey, if I could, conceivably, if the board wanted to have the same type of conversation it did last year, it may identify multiple long-acting, short-acting, etc. So reticent to say, Dan, whether that list could be 3 or 10 unto itself. That will really be dependent on board conversation, but also just continuing the conversation that I think Dr. Burns and others had mentioned about things being approved for generics. Also noting that Xarelto was approved as a generic in the last couple of weeks too. So pending how we apply those filters, we should do so consistently. Thank you.
Thank you. And so Ralph, in alignment with what you said, I was going to propose to my colleagues here today, we would have to update for the Xarelto, but I was going to propose that anything we're looking at right now, this top one, if there's currently a generic on the market that we are aware of, I would like to suggest that we remove it.
so if I do that.
But I don't think like filtering by brand and generic is going to get us because of the time frame. So it's like almost we need to do it on a case by case basis. So
Yeah, I was just looking at the top list. I'm
okay.
trying to help us start filtering because we have an hour left in our meeting and our goal is to get to our original subset list. So maybe just of the top drugs. You're right. That's a good point to say. I wasn't looking to filter the entire sheet, just the pages where we're seeing ones on the top of total spend. So like that was just the Vyvanse jumped out at me, right?
Yeah.
So maybe my amended proposal would be, let's delete the Vyvanse. We could delete the.
Well, there's about 8 versions biosimilars out there for the adalimumab, so the Humira. I mean, that is a granddaddy of expensive drugs, but I mean, by that logic, there are equivalents.
But also knowing, like what Ralph said, we can look at each drug, or the board can look at each drug individually due to the impact to the system, and it doesn't have to be the exact same methodology across all drugs.
The data call that we get, it's going to be current data, right?
It will be for 2023 to ensure it up, yeah. Because there's information that we didn't collect that doesn't get reported into drug price transparency program that we were collecting in the data call. So it's this same year of 2023 that we're getting that information. So it's consistent across that year, because that's the statutory requirement, is to review the prior year. We started collecting the data in 2024, but showing it now for 2025. So we're focused on 2023 data.
Mr. Murray?
Concerning Humira, I guess that's where I would say that, and I'm guessing since Mr. Judge isn't here, but it would be an example where we have more than 4 generic or therapeutic alternatives or therapeutic equivalents, whichever terminology you wish to use, but the price is still high and the total spend is astronomical. So, my feeling is that it should be included still, because if we have that many generics, biosimilars, are there patent issues going on? Are there lawsuits going on? What's holding things up and keeping the price up?
And
Or for that one particular version, the originator, is that what you're getting at, John?
Yes, I guess I am. If that's
Because
drug
the other 8 aren't priced the same way, and they weren't all on the market in 23.
And the other thing is, just to point out that all 11 carriers reported this as their most costly and most prescribed, but most costly drug. It came up as number 8 on the ranking scale as considered one of the most costly drugs.
So I guess my question is this then, are the therapeutic equivalents being dispensed or used, or is this solely the singular Humira NDC?
It's a Humira NDC, I believe, John.
Okay. Yeah.
So I agree with you. It's something to look at, right? Because 8 carriers still identified that. I mean, and maybe, Courtney, that's a filter we should be looking at. I know it's one we looked at in the past, number of carriers. So maybe we keep this current filter of total annual spend net of rebate, and then we also filter by carrier, so we could look at carriers that are reporting the similar.
Is there a range of number of carriers? Usually 6 or more. Can you have let me try that? And
That works for me.
All right, so based off of that filter of drugs that were reported to be most costly, greatest increase, and most prescribed, you're still looking at pretty much the top ranking most costly ones by total annual spend. So that's the Humira, Biktarvy. That gives us, that's 34 drugs. So yeah, Humira and Biktarvy didn't move. Is there any other considerations to show impact to system or patient out-of-pocket cost? Laura, raise your hand up.
I guess as we're doing the drill down, I wonder if we might think about spreading the benefit across multiple diseases so that we're not concentrating all of our focus on dermatologicals or, some of these areas have a heavy burden of expensive drugs.
I think that's kind of shown with how this is filtered by net annual rebate from highest to lowest. And oh, I didn't put antivirals. No, okay, no, that's good. Oh, sorry, John, I see your hand up.
How does patient out of pocket per year influence this? Is there
That's a great question. Most of that will come from the data call. It's a little harder to capture with the carrier data. However, it is in the insulin data that is that's identified the patient cost and the insulin data. So any of these drugs or any drug from the subset list, when it goes back to the carriers, that's where that granulation of information comes in.
Okay. I just remembered seeing it. It must have been in the insulin data then. Thank you.
Yeah, Chair Bailey.
Thank you, Courtney. One thing I recall from last year that I thought was a really good point that Dr. Hartung brought up was scrubbing the list we're looking at, what do we have, 30 some here, to see the alignment of the CCO list versus, like, to see if what there might be overlap or where there may be, I want to ask, is this including CCO? Okay, so, okay,
Yeah, so we have some of them over here.
got it. Okay, so we can see over here what's not on the CCO list, and a lot of that would be, okay.
Yeah.
Thank you. It was just an important part of consideration that I thought was relevant from last year to keep in mind. That we've
Yeah,
seen
and
something.
to also point out, these are the same drugs that were on last year's review list as well. So they were already indicated, and I know we're not really focused very much on the manufacturer list right now because or the drug reporting, because it's very challenging to get any meaningful setup for that data. But there's at least 2 that were reported as an annual increase or put on the specialty list for a change.
Thank you. So, I mean, kind of maybe something Dr. Hartung alluded to earlier in the meeting. Now I'm looking at, we have 34 records, right, that are kind of presented based on these filters. With our remaining 53 minutes, go ahead, Ralph. I see that your hand is raised.
Chair Bailey, as you mentioned that, and she scrolled all the way over to that far right side, if you'd be so kind again, and looking at the 24 IRA list and hearkening what John Murray mentioned earlier as a business owner, that he has seen some movement in the marketplace, at least on the perhaps on the 2024 selected drugs in terms of price. I wonder if he might be able to speak to that. That's not an analysis that we as staff had trended. But John, if you have any anecdotal or real observations about what you've seen in the marketplace with commercial carriers and other purchasers for those drugs, that might be informative to the board.
Sure, I guess my thoughts or experiences are most with the insulin. So when we see insulin prices change, I wonder if Vice Chair would have more input on that. I mean, I see it in the insulin prices went down, and they went down for other lines of business as well, not just Medicare Part D. So I feel that it did have an influence. But if
okay, no, if that contact was specific to insulin, I appreciate that. Thank you.
So Courtney, Dr. Hartung, your hand is raised. You have the floor.
Oh, I was also going to mention that in the IRA, there was provisions about inflationary increase in list price as well. And so I can't recall off the top of my head if that's in effect now, but that certainly probably is going to have an effect in terms of list price escalations that may be already happening independent of the negotiations.
So Courtney, one thing I was going to maybe suggest with our 51 minutes here is that since we have 34 records before us right now, maybe it makes sense to just start going line by line and having a discussion, especially with Ralph's reminder that we don't have to look at everything in the same way possibly. So, I mean, the Humira discussion we were having, I think, is one of those ones that has high total annual net rebate spend and does have other products on the market. But I think it might be the time for us to start walking through these. Is that do any board members have any challenges with that, or might we start walking through these 34 as we look to get our first list? Dr. Hartung?
You're on mute, Dr. Hartung.
Just another process question. These 31, like if that ends up being our list of to be considered, that would that list be winnowed down? Then how do we get from that 31 to the 9 that we do the affordability reviews? What's that process like?
So again, right now we're still in kind of rule 10 where it's just removing drugs that don't meet the criteria that the board feels is needed for a review. And then you go over to Rule 20, which is also the statutory requirement that follows, looking at the health inequities, the number of residents. Again, some of this information that hope to get from the request for information. And so those will hopefully be decision points for the board to look at the subset list in that capacity. So basically, you'll have to utilize these components of it to drill down to identify the 9.
When does that happen? Sorry.
So as soon as you collect the subset list, we send that subset list with the carrier data or for the data call to the carriers. We get it back. We develop those the material packets. You may recall, like last year we did, Ocrevus and Trulicity. We had those big material packets, and that is what are kind of the decision points. You review the material, and the board will make the decision through the discussions of what the impact is to either the system or the healthcare system or patient out-of-pocket cost.
Ralph, your hand was raised.
Thank you. Dan, stated differently, if the board selects or narrows this list down to 25 drugs, staff will in fact prepare 25 affordability reviews. It will then be incumbent on the board to identify 9 of those 25. So hopefully that's the context.
So
going forward.
9 of this list, let's say 30, let's say this 30 here. Let's say 9 of that list, we'll have 30 affordability reviews for those 30 drugs, and then we identify 9 that are affordability challenges from those reviews.
That is correct, yes.
Okay.
For Layman, your hand was raised.
Yeah, I was just going to suggest, Chair Bailey, that we sort of reverse filter what we have here to look at the lowest annual spend. If we're going to go just in terms of not having tons of time, and maybe we could say, hey, that Flovent is not a huge number, and it would be easy for us to take that off the list and maybe to get to the 25 a little quicker than starting with those big ones at the top.
A good suggestion. Thanks.
That makes sense. And Mr. Murray, you had your hand raised.
Yes, I guess I'm thinking maybe a little bit differently in that I want to get this. It seems to me that what we're looking at right now, from my perspective, is plans and what's the plan paying. And we're not, and I understand that there's no patient data on here and that we'll get it with the data call, but I want to get it down. I want to start thinking about the patient, the most number of patients that walk up to my counter and can't afford their medicine, these brand names that are on this list. There's quite a few on here that are challenges. Symbicort, Vraylar, Adderall even.
Number of enrollees maybe on this. I mean,
Yeah,
I appreciate the efficiency Mr. Layman referenced, but number of enrollees makes sense. One thing I wanted to remind all of us on too is one of our suggestions also to the legislature was to amend our language to make it up to 9. Now, obviously, we're not operating under that context right now, but that was one of the recommendations that we made. So Courtney, with Mr. Murray's suggestion, you have the floor.
So I did do by the number of enrollees that reported. This is fewest to largest. So that's one way to look at it. So again, like we know that Ocrevus has a smaller number of enrollees, but is also considered one of the larger overall spends. Let me see. Yeah. So 1, 2, 3, 4, 5. So just to visually see in comparison. So you're looking at a very small number of enrollees that the carriers are spending quite a bit on for these 3 drugs. Oh, sorry, Dan, or sorry, John, it's your hand up there.
No, that's fine. I'm looking at this end of the chart. If there's a way that we could maybe consider dropping off the ones that have less than 150 number of enrollees and the spend is not in the top 10 or top 20. Your highlighted ones, you know, there might be less than 150 enrollees, but there's still a high spend. I'm not sure what the threshold would be to make that determination, but maybe we could drop off some of them that are 32 enrollees, only 3 million. And I understand that's a lot of money, but when we start looking at the list that we've got, there's a lot higher number of enrollees and higher total annual spend.
Well, I think that could be a strategic, discussion for the board, right? Do we want, Dr. Burns, your hand is raised.
Yeah, I don't agree with that. I wouldn't advocate for that. Some of these, I know we have a low number of enrollees, but they're very expensive and the out-of-pocket to patients can be enormous. And when we're talking about oncology, like that really comes down to like life or death for people. So.
Yeah, Chair Raven.
Yeah, I think one way maybe of filtering is we look at the number of enrollees, but maybe we flip it. Maybe we start with the greatest number of enrollees and we start going through it.
And again, I just highlighted the top 12 of the most costly, just as a visual comparison. I can expand that out to more for the board if they wanted just to know what ones are considered the top costs of drugs in comparison to enrollees. If that's a strategy.
And again, we're working in an ecosystem of 34 drugs right now to be mindful, right?
Yeah, 34. Yeah.
Okay, so like one suggestion I would personally make is, and please clinicians here correct me, is Advair currently generic? So I would make a recommendation that we remove Advair.
Okay. Any other feedback from board members on that? Okay. I like Amy's thumbs up. We're gonna hide that away.
I would make a recommendation on Symbicort.
All right. Any other suggestions for Symbicort? Thumbs up, thumbs down from other board. All right. Thank you.
I believe Adderall XR has a generic now. I would make a recommendation on Adderall XR.
It does.
Clinicians here, what else is generic that may not have a big anomaly? I think personally, I think Humira has a reason to keep looking at it, but Mr. Kennedy, your hand is raised. You have the floor.
Yes, Courtney, could you scroll left, please? So we can look at I'm still stuck on the drug also on CCO list screen.
Oh, that may be yours. Do you want to look at that, you said?
Well, yeah, I would just like to scroll back over to where the drugs are listed, if possible.
You may be frozen.
Yeah, your screen may, because I am showing the list of the drugs themselves.
Okay.
And you may have to refresh your video. Any other suggestions from board members on drill down? Dan, okay, thank you, Dan Kennedy.
Is Farxiga generic now, everyone?
This one here.
It is, yeah.
All right, I can remove that off.
I personally believe that we looked into Biktarvy and it had an orphan designation for certain indications. So based on that feedback, if that's accurate statement of mine.
It doesn't seem to have an indication.
Okay, I thought it had a
leave it on the
pediatric.
list and we can drive down further, and then it can be one if need be to review.
Yeah, I thought it had a pediatric indication that someone made us aware of, but I would only recommend that if that was accurate.
Okay. But no, it was not indicated on our list as one. Again, Amy, I might have to lean on you, or Lori, for any other drug that from a clinical
Well, Flovent has a generic. I don't know why it says it doesn't on here.
Alrighty, I can remove that one.
I'm not aware that Entresto has gone generic yet, but it's possible. I'd have to look it up.
Lori, I see your hand is raised. Do you have the floor?
So some of these anti-diabetic drugs are kind of currently, obesity drugs that are very broadly advertised. And is there any way that we can think about what makes sense with, if we're going to prioritize equity and also look at a variety of health conditions? Is there a way we could drill down a couple of those?
Maybe not at this process when we get to the material packet of information, but we don't have that as part of our data setup. So what we're focused on right now is trying to get drugs to drill down to the subset list based off of this listing here.
And I don't see any obesity drugs on here. There's no Wegovy or Zepbound. Oh, Victoza, that's generic too. The liraglutide, 62, line 62.
This one here. Oh, sorry. Amy, you said this one? Okay. Sorry, you keep jumping around on my screen.
Mr. Lehman, your hand is raised.
Chair Bailey, on the FDA website, Biktarvy does have an orphan drug designation for pediatric
For
patients.
pediatric.
Yeah.
Yep. Thank you for, that was why my hand was raised too. So based on that information that we are aware of, I would delete it. And again, keeping in mind, we may become aware of things like that for other indications that we weren't aware of, that we will learn. But thank you for confirming that.
All right, hiding that one. I think we're down to, this is 22 right here. So I'm not sure if there's any more that the board would like to consider removing, or if you're content with kind of this drill down. Oh, Chris, is your hand still up from? All right, I just want to make sure that there isn't something else. Mr. Kennedy. I see your hand up, but I'm not hearing you.
Yes, I have no questions. Thank you.
Oh, okay.
Perhaps now that we have 22, when I look at the bottom of the screen, it still says 34 records, but Courtney, I'm hearing you say we have a list of 22. Is that accurate?
Oh, hold on a second. No, I'm sorry, 27. We have a count of 27 right now.
So what I was gonna make a suggestion on is that we go, and I know some of our screens maybe are freezing, but maybe we go slowly through it so that board members can think and see it now that we've applied some of those filters.
Okay.
Keeping in mind that we will be also doing the same process for insulin.
All right. So I guess starting at the top, Ozempic. Does the board want to keep that on the list? And I'm just going to highlight it green. And you guys do a thumbs up so I can see kind of board intent.
And maybe for efficiency, maybe as we go through it, if someone doesn't want it on or wants to speak more, that's a way.
Okay.
Dr. Burns, I saw your hand was briefly raised.
Sorry, I agree. I think it might be more expedient for the people who disagree with something to speak up,
Okay.
maybe?
Sounds good. So then Jardiance. Dan, can I still see your hand up? Did you have something? No, okay. All right, hearing none for Jardiance. Eloquist. Hearing none from Eloquist. Trilicity. All right. Botox. Seeing no comments. All right, Xarelto. Okay. Tamara. Sounds good. Manjaro. All right, Entresto. Sounds good. Epoxant. Sounds good. Ubrelvy. Okay. Concentrix. Herbolus. Devoy. Creon.
One question on the Creon for the clinicians here. Does Creon have the pancreolipase generics, or is there not a true Creon generic?
There isn't a true
Okay.
Creon generic there, but there are, we were talking before about alternatives. There are alternatives on the market,
Okay.
but
Just
not
wanted
an
to confirm
equivalent.
There's
Yeah.
not. Okay, thank you for the confirmation.
Nurtec. Emgalti. Oh, sorry. Trilogy. Sorry, Varial. Trampa. Crevice. Adasi. Enva.
And
Okay.
Courtney, can you pause related to the Odefsey real quick? I just, keeping in mind, we have 27. We also have our insulins to talk about. I did just want to make sure it's the will of the board, because Odefsey is a medication used for HIV. We had talked in previous conversations that for some people, those were drugs that they did not want on the list. I just want to make sure it's the will of the board before we proceed, that we do have an HIV agent such as Odefsey on our list. If anyone doesn't want it on there, please just make sure to say something right now. Okay, Courtney, thank you for continuing.
Yep. Rosinio. Brigetta. Peltz. And Ibrance. All right, hearing no specific feedback, board, we have 27 carrier drugs to go onto the subset list. Does that sound good to the board to move these drugs forward to review under the subset list?
We checked. I think there might be a generic for Ibrance. I can check.
For Ibrance? Okay.
And while that's being checked, Dr. Hartung, I see your hand is raised, so you have the floor.
Oh, just, do we want to set a minimum, a floor on the number of individuals who are reported in here? Because those last 3 or 4 are like fewer than 100 people. And I get the, they're expensive and
Yeah, Ibrance doesn't have a generic. I would just say like at least for like the Verzenio and the Ibrance, I know we don't have a lot of people using it, but they're very expensive and those co-pays, co-insurances can be extraordinarily high. So I personally would like to see some oncology in here because the price points can be really high. But I mean, if the rest of the group doesn't agree, because I think John brought up the same group, then I'm fine with it. I just think that there's a place for including these into the conversation as well.
Lori, your hand is raised. You have the floor.
I agree with Amy. I think it's important. The severity of illness and the high cost to the patients, I think we should include that.
And again, with the intention of these drugs going back to the carriers for additional information, we should be able to have a better, more accurate data coming back regarding, what the impact is to the patient versus the system. So, that's where the board's discussion for removal additional to identify the 9. So we can keep it on for now, see what the report information is, and then remove those or that no longer fit the category for review.
Courtney, one thing I would say related to these where we have a small N number, I would say that if they are included on our list, we do need to be exceptionally mindful of feedback we receive in the RFIs from consumers, because I don't want to see any inadvertent PHI disclosure solely because the sample size is so small. So if they are on our list, I just want to flag right now for awareness that that is something that needs to be top of mind for all of us here today.
Absolutely, yeah. All right. Thank you for the conversation and the initial selection of the subset list so we can move this forward. I'm gonna have to stop sharing screen for just a minute so I can save this document.
Courtney, while you're saving it, I just do want to be very mindful. Does this give us enough flexibility to have staff resources available for what we need to do for the insulin list? Does this list of, I was ideally hoping to see us have a list closer to 25. Does this give us enough room to have meaningful and capacity for what we need to do for insulin? I just want to make sure I'm asking staff this before we settle on things.
I believe so. We can start discussing the insulin list and then see where those go. Because remember, the insulin list does provide the impact to patient out-of-pocket cost and the system. So we'll probably have a little more clarity on, how quick we can drill down to those. And another option is if the board wanted to continue the discussion with insulin, if you haven't decided on insulin products for this go around, we can bring it back for next time. We would just have to submit an extra data call back to the carriers for just insulin products, which would probably be a much smaller list anyway. So, but we can kind of navigate how that will be for the carriers. We don't want to overburden them with administrative issues, but we also need to make sure that you are selecting the subset list that is most meaningful for your review.
Okay, so I'm hearing you say that is a manageable list for us to proceed with, is what I'm hearing you say.
Yes, for now.
Okay. Then while you're saving that, I do want to just let the board know then it would be my intention that after she saves things and that we vote to approve this initial subset list. And so I don't know if that list is, if we need language on the screen for that, if what we
Yeah, so I believe Steve, there should be a slide. I just, again, since Steve will put up the language for a vote for these, it just again for review for the board that these are the selected drugs.
All right, did I take over? Can you see?
But maybe a little prematurely. Maybe we could make sure to jump back at that list. Sorry, Steve. I know I asked for it and then I changed my mind.
I'm here. I'm doing my best here. So you can take it.
Johnny on the spot helps us all. Thank you.
Okay.
Courtney, if we could just look one more time, I want to give all the board members time and grace to be able to look at this. And
Can you see my list again?
I can.
Let me make sure. Sorry, I can't make it any bigger or smaller to fit everything on one screen, but hopefully the board can see. Provide any questions, clarity. All right, you ready to vote?
I
Hearing
believe.
nothing, Steve, you can post your motion.
Hold on. Now I moved it. All right, you see this up. Okay, and wait, first, do we have a motion in a second, or do we want to?
I'll make the motion.
Okay.
To approve prescription drug subset list for affordability reviews as discussed by the board today.
I'll second it.
All right.
Motion in a second. Yeah, Steve, if you could please call roll.
Will do. And I just had a little alert that Zoom may die on me. I hope not. I'll race through this. All right. Dan Hartung.
Yes.
Lori Hoagland.
Yes.
Dan Kennedy.
Yes.
Chris Lehman.
Yes.
John Murray.
Yes.
Vice Chair Amy Burns.
Aye.
And Chair Shelley Bailey.
Aye.
Yes. Motion passes.
Please finish. Motion passes. Okay,
Yes.
thank you.
Okay.
I did want to ask though a process related question. Did we need to like verbally read out the drugs by name? This is more a question for staff. I just want to make sure related to that vote. Obviously, board members saw it on the screen, but are we fine with that motion and vote without reading the drugs name by name?
Chair Bailey, the intention is they do not need to be read. They will be put in the minutes. So the whole list will be put into the minutes for further review.
I appreciate that answer. Thank you.
All right. Well, thank you again, board. Very grateful for your decision today to move this process forward. I know we're kind of getting to the last bit of our meeting. Did we want to touch base with the insulin drugs? Does that work?
I think it makes sense to get started. Courtney and Heather, I think I would like us to at least have it before us. We could start our discussion and our logic related to it. It may or may not lead to a vote today, but I think we have 22 minutes remaining that we could use wisely.
So does the board want to start looking at the dashboard for options or back to the spreadsheets? Would it be better to do kind of visualizations?
I'd like to see the dashboard. There's been a lot of work on it, but I do think the spreadsheets help us at the end, but maybe we could start with the visualization.
Perfect. Heather, if you don't mind sharing your screen then. Thank you. All right, I'm kind of again applying the same logic as before. Is it the board's intention to review just brand name drugs? And hearing none, Heather can filter out generics and just show brand. Thank you. There's no orphan drugs on this list, so I have to open it back up to the board to provide some feedback to staff on what are other ways to look at this. Heather, if you go to the next visualization. So this visualization shows the overall spend to total prescriptions filled for insulin. Again, with the bubble size indicating the total prescriptions filled. So the larger the bubble, the more prescriptions, the smaller the bubble, the fewer prescriptions, and then kind of where they land on the chart. I don't know if that's a start of a discussion point for any of the board. Oh, yes, John, I see your hand up.
I guess I have the same concerns as I had on the previous set of data, except that I think we have patient out-of-pocket data on this one. I'd be curious to see total spend for plan-wise, but then maybe number of enrollees and then out-of-pocket. Just I don't know if anyone else agrees, but that would help me.
And is that reference to the overall spend or just the overall spend for patient out-of-pocket cost?
Overall spend for the plans, and then number of enrollees, and then out-of-pocket spent per prescription, I guess, or per year, whichever.
So Courtney, with this, we would be filtering and sorting one or the other, not both. So if we wanted to continue here, we could, or we could look at it from the spreadsheet.
Yeah, good. Is there one that's already set up with for patient? I think we had a couple that had patient cost on it. So that's the overall spend and prescription filled. This is the payer one. Okay, so this is the patient paid per prescription versus the total prescriptions filled in alliance with the gross total patient paid, not the overall spend, but this shows the cost for out-of-pocket costs most readily. Again, with the bubble size and indicating more prescriptions were filled for that drug.
There's also this page, which
Oh,
is the total patient paid, so the size of the bubble.
Okay, awesome. I think that's what kind of, maybe missing one filter, John, but this was kind of what you were asking for through the visualization. And then Dr. Hartung, I saw your hand up real quick. Did you have?
Oh, yeah. I was wondering if we wanted, had a recollection the last time we had a similar discussion that we approached it from like a insulin subtype standpoint, like one long acting insulin, one rapid acting insulin. Just because we're kind of overwhelmed. There's just so much use of glargine and its biosimilars that they kind of dominate these figures.
Let me do a quick coloring. And then might need to still screen Heather for them to see the. Sorry, trying to do this as quickly as possible.
It's just a suggestion to consider. I don't know if it's what we want to do or not, but
Dr. Hartung, to me, it was a rationale that didn't make sense last year and helped us with kind of the overwhelm.
it did or
To me
didn't.
too,
No,
Dan.
I felt it did.
I think it
felt
does make sense.
did.
Okay,
Yeah,
okay.
I felt personally it was a helpful perspective to view it from.
Okay. Me too.
Still screen real quick. Thanks, Word. So what I did is I went through and broke these up. So these are the subclass, the insulin mix, the intermediate, long-acting insulin, rapid, short-acting. And if I remember, we filtered out, so say long-acting insulins did by overall spend. So just as a reminder, overall spend is a combination between total payer paid and total patient paid. So this is based off of the combination of the payment, or we can drill out to either one of these other viewpoints. Yeah, Chair Bailey.
I mean, From my perspective, overall spend would seem to encompass both patient and payer.
Okay.
Just from my perspective, it would seem like a lens.
Good. Actually, let me see if I can freeze my screen real quick. Oh. So last time board selected a couple drugs from each category. Is there do you want to still look at the overall spend for these and select a couple, or knowing that some of these are based off of utilization of how many scripts were filled? Laura, I see your hand up.
It looks like there's a few of these that had total unique patients. That last one is pretty low. And I would think we might be able to sort them out.
Yeah, they're kind of already in some sort of categorization based off of overall spend.
I mean, is that just 23 people for?
Yeah, so that's 23 people over 45 prescriptions filled.
But if I may, and to Dr. Burns and John Murray's point previously, if one of the focus points has been on highest paid out-of-pocket costs, and if I'm reading that right, that is in fact the one with the highest in column R. Is that correct, Courtney?
So this would be patient paid per prescription, or
And
sorry, yeah, patient paid. So if we were to filter that, that's what they paid.
So to that point, that actually would be the one with the highest patient out-of-pocket cost, despite the lowest gross utilization. So I would circle back to Dr. Burns and others that expressed concern about dismissing drugs with lower utilization, but still high cost, out-of-pocket cost.
Yeah, sorry, and I was looking it up. I think Levemir is off the market. It went off the market in 2024. I'd have to double check that NDC. I just don't want us to that's 012. I don't want us to flag something that and get down that path where there won't be any utilization for it going forward. So.
All right. So board again, are you interested in viewing just out-of-pocket costs for patients and grabbing a couple of insulin products from each subset class?
Dr. Burns has her hand raised, and then I'll. Oh, I mean, I would say I wouldn't only be looking at out-of-pocket patient. I would not, is my comment. I would be looking at overall spend from my own perspective, and then we need to keep discussing unique patients from my.
So again, it's filtered right now over overall spend. Atlantis being the top. And John, I apologize for kind of putting you on the spot, but you had made reference that some of the you see as the pharmacist kind of not just the utilization, but the cost of some of these drugs for patients. Is there any one that's kind of stands out to you that the board should consider reviewing?
Well, I guess I wanted to help the most number of people that we possibly could. And so then you would look at overall spend versus, 23 patients in the state of Oregon. So and where there's 17,000 with Lantus and Basaglar with 13,000. So I guess I'm kind of changing my focus a little bit. If we can get, I think we better try to help as many as we can. The overall, the patient paid per prescription is pretty low on those though, when you look at it. Which is amazing to me because if generics or biosimilars are available, why are we spending so much money on brand name Lantus? How are formularies being manipulated? In my opinion, that's my guess I would say. Too candidly, probably.
Mr. Hartung, your hand is raised.
Oh, just wanted to note that this is gross costs. These aren't net costs, and insulins, a lot of these have quite large rebates and discounts. So the payer amounts is going to be a little bit misleading, I think. I mean, I think it'll points in general direction, but yeah, and Atlantis is probably high utilization because of the rebate negotiations that are advancing it on formularies and things like that.
True.
Mr. Burns, your hand was raised.
Yeah, along those lines, this includes Medicaid data, right? So that would be why Lantus is probably popping up at #1 because the state favors Lantus. So again, that comes back, we're looking at gross, as Dan said, not net of rebates. So like what the ultimate cost to like a state in a Medicaid program, and it's a hypothesis because I don't know what those rebates look like, are probably pretty big.
And that's why we're trying to get the insulin drugs over on the subset list as well, because once we look at it, like what carriers are covering, we can see what the discount, impact is. So again, I know APAC isn't as a challenging database to work with, but it's what's reported.
And Courtney, you raised a good point that I think just for matter of public record is good to reinforce, right? We are using it from APAC. And, but I guess I do kind of want to clarify or maybe redact one of my comments that like we're looking at overall spend. I don't want to muddle it against total number of prescriptions filled because then that's in just a volume thing. I mean, from me, it really does look when you look at the overall spend of some of these drugs at the bottom, right, that have few numbers of patients and high overall spend to the point of kind of to the Dr. Burns' point about oncolytics. I mean, some of these things, again, we don't have, I guess to lean it or to follow up on Mr. Murray's comment, we don't at this time, have upper payment limit authority. So any discussions we're having are truly to shine light on things that are going on in the supply chain. I certainly, when I see some of these rows that are bottom on the list, those would be things I might want to shine light on trying to identify why the sample size is small and the costs are large. That's just my personal opinion. I do also want to mention, I do fully intend on ending the meeting on time in 6 minutes. So we won't be finishing this discussion, but I wanted to mention that. Someone had their hand raised though. I want to be respectful of it.
I just had a quick comment just for folks to ponder as we move into for next month. But like, some of these like specific insulin glargine products, there's, 8 to 12 biosimilars. And I don't know, part of me thinks it's like we're not going to get a good picture of the entire market for insulin glargine just by if we just selected one of these things. So I almost feel like if we select an insulin glargine product, that we need to look at every biosimilar and innovator glargine to get to truly understand in an effort to kind of shine light on this. So
Can we
just a
do
comment.
that? Because I think that's a great idea, because no matter how we slice this, like if it's looking at Lantus, which, obviously is up at the top there, you're right. There's too many other options. So, and when we looked at the long acting, it's essentially glargine, degludec. glargine. So, and then the biosimilars aren't even on here. So is that something we can do, Courtney?
You can pull this insulin data however you want to look at it. So
I like that idea. I think it will be complicated, but I think that would be a much better idea, like a picture.
and so Dan, can you provide a little direction of what you were saying again and for your review? Let's see if I can.
Maybe we can just table it for the next time, but if we just identified the most utilized and, you know, at least on the face of it, expensive insulin and all of their biosimilars, we could then kind of, it wouldn't be like a class review, but like the specific molecule and all of the biosimilars with that molecule to understand more kind of what's going on. Because I feel like just selecting one biosimilar, we wouldn't, it would be an incomplete picture of the totality of what's happening. I know that's a big ask, and maybe that's just, we just select that one for the insulins and just say as it's almost like a learning, because it'll be a learning experience. But
With
I will
our
think,
statute, could we do that? Because we have, right now, our current statute is we have to select one insulin, but if we did it this way, are we meeting our requirements of statute? Or Dr. Burns?
The statute is at least one insulin product, but the hope would be to have a few insulin products to put on the subset list to have send over to the carriers as for more meaningful report for insulin products. So, but I think since we're kind of up against time, we can bring the insulin discussion back and then make a decision and a vote next month.
Absolutely. Dr. Burns?
Yeah, I was just gonna say, if it's really hard, I think that Dan was kind of, I like where he's going with this. We could pick something like Lantus and Basaglar, or Lantus and Semglee, or Lantus, Basaglar, and Semglee, because what you're seeing here is the market opening, right? Because Lantus is going to always, it's the first glargine, and then Basaglar came out. And then after Basaglar came out, we had a couple of biosimilars and Semglee came out. So you're seeing like the expansion essentially of glargine out into the marketplace. And if we can't look at all glargine, and that's a lot of glargine, maybe we could pick 2 or 3.
Okay. Well, with that, thank you, board, for all your wonderful discussion and guidance today. I think we've definitely made a big step forward with the carrier subset list. So Chair Bailey, I'll hand it back over to you and look forward to talking with you all next month. Thanks.
Thank you, Courtney. So the next board meeting for everyone's records is on April 16, 2025 at 9 a.m. And there being no further business before the board, all in favor of adjourning the board meeting, please say yes.
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 And any opposed, please say no. All right, meeting is adjourned. Thank you, everybody.